So hi guys, today we'll be talking about our next teaching video, which is fetal skull. In last video, I have talked about maternal pelvis. I know that was a long and boring topic, but it was very necessary for you. And this fetal skull topic, this is a smaller topic compared to that one, but it is equally important. So I think this is important as a whole. Maternal pelvis and fetal skull is important for both your practical and theory point of view. So just listen to the video carefully. Try to have the fetal skull along with you while you watching this video, and I think you will understand. And I have made the PPT in such a way that if you need to write a theory answer, you can just write from this one only. Okay, so let's begin. Oh, you know what is fetal skull? It is a bony framework of fetal head, and this is the largest and least compressible part of the fetus. So, in a fetus, head is bigger than the abdomen, as you should be knowing. So, this is the largest and least compressible part because you can compress the softer part relatively easier than the bony hard part. So, it is least compressible and it plays a vital role during childbirth. It encases and protects the brain. Okay, and the parts of the fetal skull is vault, base, and face. So the upper one is vault, the lower one is base, and the front one is face. Okay, vault, base, and face. What are the bones of the fetal skull? As you know that the skull is formed of bone, so the vault is a large dome-shaped part above an imaginary line. So you should be knowing from where the vault starts and from where the base starts, from where the face starts. So vault is very important part of the skull, and the diameters and the functions revolves around the vault. So it is a large dome-shaped part above an imaginary line drawn between the orbital ridges. So these are the orbital ridges. So if you draw an imaginary line, and the part above it forms the vault, okay, and the nape of the neck, okay. So actually this is like this. And the base is comprised of the bones that are firmly united to protect the vital centers in the medulla oblongata, in the midbrain, pons, etc. And the face is comprised of 14 small bones, as you know, as in adult face also. And the face part is non-compressible. The base part is also not compressible to some extent, but the vault is compressible. Okay. What about the sutures of the fetal skull? As you can see in this diagram, it has two longitudinal sutures, this, and two horizontal sutures, this and this. So the first important suture is sagittal suture, which is this, formed by the junction of the two parietal bone. And the next important suture is coronal suture, which is formed by the junction of one parietal bone and one frontal bone. Okay, so this one is coronal suture, sagittal suture. Lambdoid suture is formed by the occipital bone behind and the parietal bones in front. And the metopic suture, which is formed by the junction of two frontal bones. In adult life, this will not be there. This suture will not be there because the frontal bone, fuses. The parts of the frontal bone fuses and forms a single bone. But in fetus, you can find a suture there. So all these are the important sutures. And what are the importance of sutures in the fetus? Why the sutures are membranous in the fetus and bony in the adult? So obviously when it becomes bony, you cannot compress. There is no space. But in fetus, you can see the suture is membranous. So the bones may glide over the suture and it will help us in some ways. So what are the importance? I have written it in point wise, so it will be easier for you to answer during your viva or even write during the exams. Okay. So it permits molding of the fetal skull during labor. It helps determine the fetal position by palpating the sagittal suture. So if in further videos I'll tell you about position, presentations, and etc. in details, while I teach you about the mechanism of labor or induction of labor and progression of labor. So there you will know that sagittal suture will help us in knowing if the fetal head is in anteroposterior direction or in transverse direction or in oblique direction. It will help you in knowing if there is ongoing rotation, internal rotation of the head or not. If there is no ongoing rotation, if you are feeling the suture in the constant horizontal way, then it means there is deep transverse arrest. But if you can feel okay, it was in transverse, now it is oblique, now it has become more vertical, now it is completely vertical, so you know that the rotation is complete and the labor is progressing normally. So in that way it will help you in knowing the fetal position. It helps assess the degree of flexion and extension through fontanelles. So if you can palpate the posterior fontanelle in your PV examination, that means the head is flexed. If you can palpate the anterior fontanelle, it means the head is extended and the delivery will be difficult. So I'll tell you the difference between the fontanelles and how to identify which one is one in further slides. It also indicates a descent and internal rotation, as I told you. It aids in diagnosis abnormal labor, malpositions, CPD through assessment of molding. Okay, so if there is no descent of fetal head, there is some disproportion. Okay, so in that way you can know from sutures and fontanelles. Now fontanelles. There are two fontanelles important: anterior and posterior. Anterior one is also known as bregma, and the posterior one is lambda. Okay, and what is the difference? The anterior fontanelle, as you can see, is diamond shaped. Okay, it is quadrangular. It is formed by the four bones, two parts of the frontal bone and the two parietal bones. And the posterior fontanelle is triangular, somewhat triangular in shape, and formed by the three bones, behind by the occipital and in front by the two parietal bones. It is smaller in size as compared to the anterior fontanelle, and the anterior fontanelle closes at 18 months and the posterior one closes at 6 to 8 weeks after birth. So what are the importance of the fontanelle? So the clinical importance are: number one, as I told you, it will help in determining the fetal position during vaginal examination. So if you are palpating the posterior fontanelle, the position of the fetal head is in which attitude? Flexion. Okay, but if you can palpate the anterior fontanelle, the attitude of the fetal head is in extension. Number two, it helps in assessing the degree of flexion or extension of the fetal head. Number three, it facilitates molding during labor. So, the space is smaller and the fetus is going through the pelvis. So, if there is molding, that is gliding of the fetal skull bones over each other, then somewhat the passage will be relatively easier. But if there was no molding, just imagine the delivery process would have been much difficult. Number four, it helps in differentiating between vertex, brow, and face presentation by assessing the fontanelle. Okay. Number five, it assists neonatal health by detecting dehydration. So if the fontanelle is sunken, then it indicates dehydration. If it is, swollen up, then it indicates raised intracranial pressure and abnormal skull development. So what are the transverse diameter of the fetal head? As in pelvis, you have read about the inlet, cavity, outlet, their transverse, anteroposterior and oblique diameters. In fetus, there are transverse diameters and there are anteroposterior diameters. So first, and these are very smaller in numbers as compared to the maternal pelvis. So relatively easier for you to understand and learn and remember. Okay, so the diameters are biparietal diameter, subparietal diameter, bitemporal diameter, and bimastoid diameter. Rather than mugging up, just try to remember by the name. Biparietal diameter. Obviously, it will be on the parietal bone. So, There is parietal eminence on the parietal bone, as you know from your anatomy class. So the distance between the two parietal eminence forms the biparietal diameter, and this is the most important transverse diameter which engages in normal labor. Okay, so it is 9.5 centimeter. You need to remember this number, 9.5 centimeter. Then there is subparietal diameter. So sub means below. So below the parietal eminence, there is a point, and then you join these 2 points, and that is the subparietal diameter. It is obviously will be smaller, so 8.5 centimeter, and this is the diameter of the well flexed fetal head. So in flexed fetal head there are two diameters which are important. Most important is BPD, biparietal diameter, and the next one is subparietal diameter, and it facilitates engagement through the pelvic inlet. Third one, bitemporal. So between the two temporal eminence, when you join the line, it forms the bitemporal diameter, which is 8 centimeter, and it is the smallest transverse diameter, not a limiting factor during labor. Not so important. These two diameters are not so important. The most important is BPD. So just remember it extends from where to where and what is the dimension of it. Bimastoid diameter. So between the two mastoid process, the length is of 7.5 centimeter, and this is the smallest diameter at the base of the skull, and important after engagement and during passes through the pelvis. So just remember the names in the centimeter. It will be in decreasing order. Now the important part, longitudinal diameters, that is the anteroposterior diameter of the fetal skull. This is very important, and you need to understand this to understand the mechanism of labor. So just try to understand and remember the dimensions. Okay. So the first one is suboccipitobregmatic. Next one is suboccipitofrontal, occipitofrontal, mentovertical, submentovertical, and submentobregmatic. Just try to remember from the name of the diameters that it extends from where to where, and you have to remember the numbers and its importance. Okay, so I'll show you in the diagram what is suboccipitobregmatic diameter. So it extends from the nape of the neck. So there is occipital prominence of the occipital bone, and below that there is nape of the neck. It extends from here to anterior fontanelle, that is bregma, and the diameter is 9.5 centimeter. So in a well flexed fetal head, the engaging longitudinal diameter is suboccipitobregmatic diameter, and the engaging transverse diameter is, please answer, it is biparietal diameter. Okay, so here you can see the suboccipitobregmatic diameter is 9.5 centimeter, and it extends from the nape of the neck to the center of anterior fontanelle, and it is the diameter of presentation in a well flexed fetal head in vertex presentation. Okay. Now suboccipitofrontal, from the nape of the neck to the anterior end of the fontanelle. So just see, here it is the center of the fontanelle, and here it is the anterior end of the fontanelle. So just try to appreciate. That if here is the the fontanelle, then from the nape of the neck to the center is suboccipitobregmatic, and from the nape of the neck to the anterior end of the fontanelle is suboccipitofrontal, which is 10 centimeter. Okay, so it is 10 centimeter, and it is the diameter of presentation when the fetal head is in incomplete flexion. Similarly, occipitofrontal extends from the occiput to the glabella, that is root of the nose, and it is 11.5 centimeter, and it is the diameter of presentation in sinciput attitude, that is when the fetal head is not flexed, not extended, but it is in a military position, like when a military personnel stands and his head or her head is in straight position looking just in the front. Just imagine that position, and that is the position of the fetal head when it is not in flexion or in extension. Mento-vertical, this is the largest diameter and it extends from the chin, that is mentum, to the highest point on the sagittal suture, and it is the diameter of presentation in brow presentation. Submento-vertical, obviously from the junction of the chin and the neck, that is, this is the chin and this is the neck. So from here, that is junction to the highest point on the vertex, it is 11.5 centimeter, and this is the diameter of presentation in incomplete face presentation. And submentobregmatic, again from the junction to the center of the bregma, that is 9.5 centimeter, and it is the diameter in complete face presentation. Okay, so just appreciate in the diagram. I already told you about suboccipitobregmatic and submentobregmatic, and suboccipital frontal. Now you see occipitofrontal is from the occipital protuberance to the root of the nose, which is 11.5 centimeter, and the mentovertical is from the chin to the highest point on the sagittal suture, that is 14 centimeter, and the submentobregmatic is from the junction of the floor of the mouth and the neck to the bregma. This is 9.5 centimeters. Okay, so these are the important longitudinal or the anterior-posterior diameters of the fetal skull. Now, to understand this video completely, you need to understand these, terms. So I have just included these terms in this presentation in this video, so that if you are facing any difficulty, just go through it and you will be fine. Okay. So what do you mean by fetal lie? So it is the relationship of the long axis of the fetus to the long axis of the uterus. Okay. So if this is the uterus, and the baby, the long axis of the uterus is this, and this, if this is the baby lying, then the long axis of the fetus is this. So the lie is transverse. But if a baby is lying like this, then the long axis of the fetus is this. Then the lie is longitudinal. So this is how you know if the lie is longitudinal or transverse. Okay. And now the next one is presentation. So the fetal part that occupies the lower uterine segment and presents first in the pelvic inlet. So if the head of the baby is occupying the lower pole, then it is cephalic presentation. If the buttocks of the baby is occupying the lower pole first, then it is the breech presentation. And if the shoulder part is occupying, then it is shoulder presentation. And in cephalic, there are three parts of the fetal head which may present first in the lower pole. So it can be vertex, it can be brow, it can be face presentation. Okay. So just remember, vertex or brow or face is a type of cephalic presentation. Now, what do you mean by position? It is the relationship of the denominator of the presenting part to the quadrant of maternal pelvis. Okay, so suppose if it is cephalic presentation or vertex presentation, the position is determined by the denominator of the presenting part. So for vertex presentation, the denominator is occiput. So how the occiput is in relation to the quadrant of the maternal pelvis? If it is left occipito-anterior, if the occiput is in the anterior part of the pelvis and on the left side or on the right side, that is right occipito-anterior. Okay, so position is that. And what do you mean by attitude of the fetus? It is the relationship of the fetal head and limbs to the fetal trunk. So if the fetal head is in flexion or extension, that is known as the attitude. So I told you in cephalic presentation, there are three kinds of cephalic presentation, that is vertex, brow and face. So you should know from where to where the vertex extends, from where to where the brow extends, and from where to where the face extends. So the vertex extends from the anterior fontanelle to the posterior fontanelle. So this green part is the vertex. Okay, and I told you the presenting epidiameter of vertex is suboccipitobregmatic, and the transverse diameter is biparietal diameter. And the brow extends from anterior fontanelle to the root of the nose, that is this part, this pink part. Okay, and the presenting diameter of brow presentation is mento-vertical. So suppose if this is the presenting part, the head will be extended like this. So the mento-vertical diameter, that is this, and the highest point I told you now, which is 14 centimeter. And if the presenting part is face, that is from the root of the nose to the chin, then the diameter will be occipitofrontal or others. Okay. And the clinical significance is of vertex presentation is that is it is the most common and most favorable presentation for normal delivery. So most of the most of the normal deliveries, the presentation is cephalic and vertex. So here are some diagrams to make you understand about the fetal positions if you have not already understood. Here you can see the head occupies the lower portion of the uterus. So it is cephalic presentation. Okay. And the head is in flex position. So it is vertex presentation. And the denominator is occiput. And you can see if this is suppose if this is right and this is left, the occiput is in anterior part and on the right side. So it is right occipito anterior. Similarly, here you can see the occiput is in posterior part and in the left part. So it is left occipito posterior. So this is how you determine the position of the fetal head. Here you can see that the face is the presenting part. Face occupies the lower pole first. So it is face presentation. Here you can see brow occupies the lower pole first. So it is the brow presentation. Here it was vertex that has occupied. So it was vertex presentation. Here the buttocks occupies the lower pole. So it is breech presentation. And here the shoulder occupies the lower pole. So it is shoulder presentation. Okay. So I hope you are understanding and you are going with the flow the way I am teaching you. And here I have given one tabular presentation so that it is easier for you to comprehend all this together. Here you can see I have talked about vertex, brow and face presentation. The degree of flexion in vertex is complete flexion, in brow it is partial extension, and in face it is complete extension. Just look in the diagram. In face the head is completely extended. In brow it is partial extension. And in vertex it is flexion, complete flexion. Okay. Obviously, the presenting part would be vertex, brow and face. And the presenting landmark. In vertex presentation, just look in the diagram. The head is like this, na? So the head is like this, it is flexed. So here is the anterior fontanelle, here is the posterior fontanelle. So if you do PV examination, you will be encountering this posterior fontanelle first. Here in brow presentation, anterior fontanelle. Okay, as you can imagine, in front there is anterior fontanelle and in back there is posterior fontanelle. And in face, you will be encountering the mouth or the, the malar prominences. In buttocks, you will appreciate these ischial bones of the baby. So here, posterior fontanelle. In brow, it can be frontal suture or anterior fontanelle. In face, it is mentum or chin. And I told you the extension already. And the presenting diameter also suboccipitobregmatic in vertex, mentovertical in brow presentation. And just remember the diameter can vary from 13.5 to 14 centimeter, both are fine. And here submentobregmatic in face presentation, that is 9.5 centimeter. And the vaginal delivery is most favorable in this position. And in brow presentation, it is usually not possible because the presenting diameter is mentovertical, that is 14 centimeter. So this diameter is bigger than any of the diameter of the maternal pelvis. So it cannot pass through the maternal pelvis. And here it is possible if the face is anterior, that is if the face is the mentum is anterior. In mento anterior position, only vaginal delivery is possible. Otherwise, no. And here I have give you the summary points, important summary points which can be asked in exam during your viva. So the largest transverse diameter is BPD, biparietal diameter, which is 9.5 centimeter, and this engages during the normal labor. The smallest transverse diameter is bimastoid diameter. Okay. And it is at the base of the skull. But if you look at the vault, it is bitemporal diameter, which is 8 centimeter. The largest longitudinal diameter is mentovertical. in brow presentation, and it prevents vaginal delivery. And the smallest engaging epidiameter is suboccipitobregmatic, which is 9.5, which is seen in normal vertex presentation. And normal engaging diameter are suboccipitobregmatic and biparietal. It is the transverse and this is the AP. So 9.5 both. Okay. So thank you for watching this video. I hope it has helped you. So just try to see the video of maternal pelvis and fetal skull. Uh, after every 1 to 2 months, or at least after 2 to 3 months, so that you don't forget this topic. And before your exam, before your practical, you need to see this video and have the fetal skull and maternal pelvis in your hand. Okay. So this is very important chapter. You cannot escape it as an MBBS student or as a PG student also. So whether you are appearing for your boards exam, that is MBBS or MDMS exam, or you are, NEET PG aspirant or INI aspirant, or a nursing student who is also appearing in their exam. So this video is important for you, and for whoever who are practicing OBS, this video is important. So please watch this, and if you have any confusion or any doubt, you can ask me in the comment section. Okay. Thank you.